Thank you, Usrapya. Good evening, everybody. So we are continuing with the gastrointestinal symptom management. Uh, so we covered nausea and vomiting in the previous class. Uh, so constipation and bowel obstruction, malignant bowel obstruction are the two topics which Vineetha is planning to cover today. So everybody knows Vineetha, but Mm, still, she is currently doing her MD in palliative medicine from Abdan Institute of MD in community medicine from Abdan Institute of Medical Sciences. But previously, she was working as a palliative care physician at Aster, both in Kochi as well as in Calicut. And she has done her MSc in palliative medicine from Cardiff University. And she was working alongside uh, or working with oncology to integrate palliative care into uh, cancer care. So, Vineetha, it's all right.
Thank you. Thank you, Sunil. And thank you, Talim. So very good evening, everybody. It's really nice to see all of you once again. And I think we should start off right away. Let me just try to share my slide. Yes. Is this moving? Sri Priya, is my slide on slide view and is it moving?
Yes, ma'am.
Okay. Thank you. Thank you. Right. So today we have two things to cover. Initially, our plan for today was only to cover malignant bowel obstruction, but we have constipation left from yesterday, from last class. So constipation, moving on right into the topic. So what does constipation tell you? I mean, we all know that, how to manage constipation. And we have had patients coming to us with symptoms of constipation. But what exactly is constipation? Is it that, it is just that the patient is not passing stools, or what exactly is constipation? On the chat? What exactly is constipation? Is it just that when the patient tells you that he is not passing stools? Or would you like to know something more? Is there something that you would like to ask? No responses today, yeah?
Onset, duration.
Yeah, you would like to know
associated complaints, any blood and pain.
Yes. Yes, thank you, Dr. Dimple. And you would like to know when did it start?
Whether the flatus is there.
Yes. And we also have some responses in the chat box by Dr. Stravani, who says lesser frequency than previous. That's very important because we would like to know what is his normal bowel habits. And Dr. Manjula also says pain. We have Dr. Biju saying here passage of small hard stools at infrequent interval. And again, Dr. Vidya also agrees to that. Yes, so in short, it means that it is basically a difficult and painful defecation and is associated with infrequent bowel evacuations and hard feces. And it is a subjective feeling. It is about asking the patient, how different is it from your normal? It is about asking the patient, when was it normal previously? And when he tells you he has been constipated for 3 days, the question you have to ask him is, how is it usually? If he is in a habit of passing his bowels every once in 3 days, then it is not abnormal. That is normal for him. So you need to know how different it is from his normal. And most of palliative care patients are constipated due to various reasons. Most of them are, their mobility is restricted, and the food, the diet that they have is probably changed from what it was before. Their hydration level is less, or probably due to many other diseases, also it is less. And again, the difficult or painful defecation is also important. The hard stools is also important. So basically, the symptoms probably your patient could be presenting to you is with feeling of incomplete evacuation. He tells you that, doctor, I have passed stools, but I always feel as if there is still more to go. There is a bloated feeling or nausea and vomiting associated with it, pain, like you were saying, also associated with it, bowel obstruction, overflow diarrhea. Like the other day, the case scenario that was being presented, it was about spurious diarrhea. So what is spurious diarrhea? Spurious diarrhea is otherwise called as overflow diarrhea. So when a patient comes to you saying that he is having trickling of motion and it is very distressing, you ask him the question, when did it start? Yes. When did he pass stools normally last? So then he tells you a very important clue. He tells you that the last time I passed motion was like 7 days back. And it's since yesterday that I'm having this trickling. Now, that is when you think about this must be overflow diarrhea. That is when there is a prolonged constipation and the upper part of the fecal mass starts necrosing and it starts trickling like a diarrhea. And at this point of time, you do not treat it like a diarrhea, but you treat it like a constipation. So it is very important to know whether you are looking at a diarrhea or you're looking at a spurious diarrhea. Then again, constipation can also lead to urinary retention. Many of the patients that we see at home who are on catheter, sometimes we are called because the family is panicking. They tell us that patient is not passing urine through his tube, and we go check for any blocks. And we see that it is patent. There is no problem with that. But then, what is the issue? And that is when sometimes we do a rectal examination and we find hard fecal mass impacted and the rectum is loaded. And this is what happens when there is constipation, a prolonged constipation where there is a pressure that is falling onto the urinary bladder, which causes in turn urinary retention. Now, there are different causes for constipation. They can be pharmacological causes. So you need to know when your patient comes to you with constipation, it is important to manage the symptom, but again, it is very important to know what is the cause. So is it a correctable cause over here that which is causing the constipation? So you ask him about what drugs he is on or what kind of diet he is having, where is he been taking his food, and how often is he taking food, his water. And you look at his case file, where exactly is the lesion he is having, or is there any associated spinal cord compression? Is he having any pelvic tumors? Is there anything, any reason which is probably causing an obstruction at that area? Or maybe it is just simply depression or immobility, or maybe he's just too sedated that he is not able to apply pressure. So among the drugs, most of the times our patients who are in pain, they are on opioids. So opioids are well known to cause constipation, and our patients have to be put on laxatives for that same reason. Also, there are some drugs like antidepressants, like tricyclic antidepressants. They can cause constipation. Anticholinergics, like buscopan, hyoscine hydrobromide, anti-epileptics, anti-emetics. Like yesterday, we were talking about ondansetron. Everybody's favorite ondansetron does cause constipation. And then antacids, somatostatin analogs. Now, these because they have an anti-secretory action, and this can lead to constipation, and also decreases the gut motility to an extent. Now, metabolic causes like hypokalemia. Hypokalemia is also one of the very common causes that we see among our patients. Hypercalcemia, dehydration, uremia are all other causes. Again, diet, which is low fluid in intake, low fiber intake, and maybe hospitalization. The patient has been passing his bowels fine until he got hospitalized. What else would you expect? A patient who is like admitted in a ward with patients who are there, on both his sides, lying on the bed. There are no proper barriers, and he's given a stool to pass his motion. It is not surprising if he is not constipated. I mean, if he is constipated. And also, again, some other structural reasons are there. So you need to assess by asking what is normal for him, ask about the frequency, the amount, the consistency. Is it hard? Is it loose? Is it blood stained, like you were saying? And when was the last bowel movement? Is the patient experiencing any abdominal discomfort like nausea, vomiting, bloatedness, pain? And is the patient on laxative? It's very important to know that, because the patient might come and tell you that he is on laxatives and he's still constipated. Now you are perplexed because this has happened so often. Now you have to ask him that $1,000,000 question. When was the last time you took your laxative, and how often do you use it, and are you regular with it? This typically happens because patients who are not compliant with their laxatives, they tend to, take it for a day and then they do not take it for some time, and until they get constipated. Now, what happens to a patient who is constipated for, like, say, 5 days? He takes his laxative, 1 dose, it does not happen, takes a second dose, and finally he might have to take laxative 3 times in a day. And then he has a purge. There's an absolute bowel clearance that happens. And after that, he has a bit of trickling as well on the next day as well. And this, he tries to think of it as a side effect of his laxative. Now, that is where you have to give the awareness, the education that, the symptom that you have had is because of the bowel clearance, and it is not because of the laxative. Because it is this fear that makes him stop from taking his laxative regularly. He thinks that if he takes his laxative every day, he is going to have, loose stools and trickling, which is going to be distressing. So you need to educate the patient how he has to taper or tailor his dosage of laxative to what suits him the best. There are paraplegics who are bedridden and they are given laxatives. It is only when they are given a laxative they pass to. So, sometimes it does happen that, the caretaker is not available all the time. And for convenience, they are given laxatives only once in 2 days. And as long as the patient is comfortable with that, not having bloatedness or any nausea, still able to eat properly, that's fine. So what medications are the patient on? You need to ask that. If any drugs have to be revised, that has to be done. If the constipation has been a recent change, you will have to look for other metabolic causes and what type of diet the patient is on. Now, most often, you have the family telling you, oh, doctor, how is he going to pass stools? For he's not eating at all anything properly. Now, again, you need to educate the family that even if nothing has been eaten well enough, there are intestinal secretions and he will have to pass motion. So do not consider it as normal. if he has not passed motion for many days. Then again, they have, there is another entity, which is the overflow diarrhea, which we have already discussed about. So when you manage constipation, you look for the causes and see if anything is correctable in it, especially metabolic, drug related, if it can be changed, or if it is reversible, please do the needful. And judicious use of laxatives improve the general condition of the patient. Symptom control, if the patient is in a lot of pain, there is vomiting, try to control that with medications. And encourage activity if it is immobilization, which is resulting in constipation. And if the patient is able to move around, there is nothing else which is preventing the patient from moving around, encourage him to walk for some time every day. And again, fiber diet. So coming to the type of laxatives, you have bulk forming laxatives, you have lubricating laxatives, osmotic laxatives, stimulants, stool softeners. Now these are all different types of laxatives, and they have different action. So if you have a bulk forming laxatives, it's basically increasing the bulk of the fecal mass, which in turn stimulates the forward propulsion of the fecal mass. And lubricant, it helps an easy motion. Osmotic is when there is absorption of water from the intestines, and this helps to make the fecal mass a bit more loose and help for evacuation. Most often, we prescribe our patients lactulose, and this is usually one of the favorites of most clinicians. And lactulose, as we know, is also a liver protectant. And stimulants like bisacodyl. And bisacodyl is something which is being used very commonly in palliative care, and it is prescribed along with opioids. And most often we give 2 tablets of bisacodyl at night time. And stool softeners are also used, docosate sodium, and this helps to soften the hard stools. So, few recommendations: paraplegic patients need regular stimulants and stool softeners, and they may initially need manual evacuation. Patient with colostomies can also get constipation. You need to understand that. And again, digital evacuation may be needed also from the stoma, colostomy stoma. And after obstruction is excluded, bisacodyl suppository can be used, but it is less well absorbed, and oral tablets need to be added. So if there is impacted fecal mass, you will have to do evacuation of the impacted fecal mass before you put in the suppository, because we need to make sure that the suppository is well in contact with the mucosal surface of the rectum. So soft stools, if the patient is having soft stools, you go for bisacodyl suppository. If it is hard stools, you go for glycerin suppositories. And if it's an empty rectum, that is a ballooned rectum, like how we had in the previous presentation in the previous class, you go for oral stimulants and high-end enema. We had talked about it last class. And if soft fecal masses, which are palpable per rectum, yes, we have already said that, bisacodyl suppositories. And again, coming on to manual evacuation, it is very important to explain to the patient what is the procedure you are going to do, and you have to be very patient, very calm as you are doing the procedure, because it causes some amount of embarrassment for the patient, and it is painful when the patient is having an impacted stool because it itself causes pain. The impacted stools itself causes pain. So you need to liberally use a sufficient amount of lubrication, anesthetic jelly, as you are performing the evacuation, digital evacuation. And you need to allow enough time for the local anesthetic to act. Now, we were talking about the X-ray last time during the presentation. So this is a typical X-ray where you can see the impacted fecal mass in the large intestine. And that is how it would look. So in short, to summarize, you need to know when you have a patient coming to you with a symptom, you evaluate, you manage, you monitor, and you check for what is correctable. And when you plan your treatment, you check for what are the non-pharmacological ways you can correct it. You check for the pharmacological, you decide on what are the pharmacological drugs you need to give, any interventions needed. And as you are managing the symptom, you need to manage not just the physical component, but the psychological, spiritual, and the functional components of that. Yes, so Mr. Roy is a quadriplegic who is given feeds through nasogastric tube, and he has presented with vomiting since 2 days. So this is a patient who is getting feeds through his Ryle's tube, but now he is having vomiting since 2 days and he is sick. What can be the possible reason for this patient? What can be the possible reason for this patient who has a Ryle's tube and is vomiting since 2 days and is now sick? Yes, Dr. Biju says obstruction. Obstruction, like, would you like to be a little more defined on that? Like, give some clarity on that. Where is the obstruction?
Paralytic ileus.
There's probably a paralytic ileus, which is kind of, given rise to the obstruction. Yes, Dr. Radha is also saying, check for any abdominal sound to see if the bowels are moving. Peristaltic sound. Okay, Dr. Bijit is probably a high-end obstruction. Can ask regarding the bowel movement. Okay, ask for constipation.
RT aspirate is there. The feeds that are given.
You might have to ask for questions regarding that because the Ryle's tube itself probably is blocked. And maybe there is the Ryle's tube has moved and that is also causing vomiting, or probably it can be that the patient is being fed more than he's supposed to be and the patient is having vomiting. So it must have caused some amount of aspiration and the patient may be sick. So always check for the position of the nasogastric tube when you come to a situation like this. And also ask about whether the feeds are going through, is there any block and things like that. Yes, so with that, we come to malignant bowel obstruction. We have like almost half an hour to finish that. Yeah. So when we come to intestinal obstruction, what I would like to cover today is the symptoms, how you come to the diagnosis, how you manage a case and treat it in palliative care. Okay, so you may have seen patients in your clinics with intestinal obstruction, and how do you actually what are the symptoms? Let's come to this. What are the symptoms that your patient would come to you with if he is having an intestinal obstruction?
He will have nausea and vomiting.
Yes, he could have nausea.
Colicky, most probably.
Yes.
Colicky
Yes.
pain, and he has constipation or spurious diarrhea.
Yes.
And difficulty in nausea and vomiting even with the sip of water if it is completely bowel obstruction. If it's incomplete, he would take the sips, but he would feel still the incomplete evacuation of bowels if it is partial obstruction.
All right. Okay, so we have a whole lot of answers over here as well. Like all of you have agreed that the patient could have abdominal pain, vomiting, looking very sick. Yes, probably the patient is very sick. Due to several reasons, the patient could have had accumulation of stools, hyperammonemia, and patient could be delirious, right? So you might see patients with different symptoms. And how are you going to come to a diagnosis for such a patient? You do suspect, yeah, this patient could be having this kind of obstruction. Yes, Dr. Bijou is also saying that there could be fecal vomiting if it is a complete obstruction. Yes, you could also see that. And Dr. Jagruti says that probably the patient is probably going to be totally unable to eat anything. Yeah. So how are you going to come to a diagnosis? Take an abdominal X-ray, yes. Make a bowel assessment, okay. Take a supine X-ray abdomen, yes. Yeah. So what if you do not have a facility for an imaging? Yes, Dr. Radha was saying, check for the bowel sounds if it is totally absent. And is it possible to know, like, where is the site of obstruction? Will you be able to know that at a bedside? Yes, Dr. Bijou says yes. Could you elaborate on that? You're at the bedside. Yes, it's a left iliac fossa pain. Okay. Check for RT aspiration, content of aspirate. Okay. Yes, how will you know which site it is? Where is actually the obstruction? You're going to ask the patient something. Esophageal, if the vomiting is immediately after a feed, okay. Abdominal palpation, okay, you check for where you can palpate the mass. Bilious, if it is after a duodenum, okay. Yes, so there are quite a few ideas here, and most of you kind of know, how exactly, and let's see if we can come totally to the point, okay. So obstruction, when we come to obstruction, we mainly classify it into mechanical obstruction and non-mechanical obstruction. Like how you were just saying some time back, paralytic ileus, isn't it? So there we do not have something right sitting there inside the intestine and blocking, like as if it is a tumor or a mass. There is nothing that is actually obstructing. It is just that the intestine just is not moving. So it's a non-mechanical obstruction. It's a functional, it is usually seen in functional obstructions or adynamic bowels, where there is absence of the peristaltic contractions. And in this case, the pain is usually less and there is absent bowel sound. Whereas in a mechanical obstruction, it could be an acute obstruction or it can be a chronic, or it can be acute and chronic. Maybe this person has had a subacute intestinal obstruction many a times, and now the patient is having a complete obstruction. And yes, like as we were saying, it could be in the small bowel or it can be in the large bowel. Or it could be simple, closed loop, strangulated, or it can be intrinsic. It is inside the lumen obstructing. It can be extrinsic. It can be outside the lumen, putting a pressure on the lumen and obstructing. Or it can be intraluminal, where you have the tumor invading in and obstructing. So depending on the nature, we could also call it simple obstruction, closed loop obstruction, or strangulated obstruction. In strangulated, the blood supply itself is compromised. So what are the causes? What are the causes for mechanical obstruction? This obstruction can be because of different reasons. It can be some kind of impaction over there. It can be foreign bodies, can be gallstones, if it is intraluminal, or it can be impaction of fecal mass. What if it is intramural? Intramural. So then it's probably a stricture, it can be probably a malignancy, or if it is extramural, it can be additions. Probably the patient has had multiple abdominal surgeries, or the patient has had radiation to his abdomen, which has led to adhesions, or it is Probably the patient is having a hernia or intussusception. And like we were saying, adynamic causes, it can be paralytic ileus or pseudo-obstructions or mesenteric vascular occlusions. And now coming to the causes of the symptom. Now, you did say that the patient is probably going to have severe pain, is probably going to have a distension feeling, bloatedness, or probably going to have nausea and vomiting. Now, why these? Why is he developing these symptoms? In a partial or complete bowel obstruction, there is decreased movement of the intestinal contents. Now, when there is decreased movement of the intestinal contents, the bowel gets distended. And there is an increased gut epithelial surface because of the distension. And because of this, it leads on to increased bowel secretions. Now, this in turn causes colicky pain. And it can, because there are so much of secretions, it can cause nausea and vomiting. It can also cause inflammatory responses, which in turn make the pain continuous. Now, these are the areas where we have to tackle. As palliative physicians, we have important areas looking at us to be managed. The colicky pain, the increased secretions leading to nausea and vomiting, the decreased movement of the intestinal contents. All these are glaring at us. We need to manage all these when we are managing an intestinal obstruction. So the level of the obstruction determines the pattern of symptoms. So if the patient is having a high level obstruction in the small intestine, for example, the vomiting develops early and it is a large volume vomitus, the patient or the family typically tells you that I barely retain what I have drank or eaten, but the amount I'm vomiting is so much. Sorry, were you trying to say something? Yes. So the vomiting, when the volume of the vomitus is large, we can almost say, confirm that is a high level of obstruction. For larger bowel obstruction, generally it is progressive and the abdominal distension is more for large bowel obstructions, and the volume is not as much as for high level obstructions. And if there is a complete obstruction, there is no flatus, there is no feces, or they may not be spurious diarrhea. So in last class, we were talking,
Ma'am, is there, you mean progressive vomiting in a large bowel obstruction? When you say progressive,
the symptoms gradually progress. They may not be like, acute. Yeah. So in the X-ray over here, like in the last class, we were talking about, we do not know whether there are typical air fluid levels. And this is the air fluid levels that we were talking about. This X-ray typically shows you the horizontal lines depicting the air fluid levels. So you can advise for an erect abdominal X-ray where these air fluid levels will be seen, and you can also see the enlarged large intestine. Okay. Now, coming to planning and management of these patients. Now, this is an algorithm chart which helps you to decide how to manage your patient. Who is it that you are going to treat aggressively? Who is it that you are going to probably, give only a symptom control? So when you get a patient with symptoms of bowel obstruction, you do a clinical assessment. Like I said, clinical examination of the patient is mandatory. It gives you very important clues. So when you have a patient with intestinal obstruction, probably you are going to look for signs like of any visible peristaltic waves, or maybe you are going to hear loud bowel sounds, which is called as Borgagni bowel sounds. Or you can even palpate and feel the bubbles, the peristaltic waves. So these happen when there is a typical obstruction. And you can even auscultate and find if there are bowel sounds, or if the bowel sounds are feeble or they are completely absent. And then you have the radiological findings. Yes, X-ray, erect abdominal X-ray for your air fluid levels. You can probably even go for higher imaging like a CT scan. Now, coming to the decision making. Coming to the decision making of how to manage, how aggressive to manage, to be precise. These are some patient factors which are going to help you decide. And on the other hand, I have some disease factors which are going to help you decide. So patient factors, I have put age over here. But again, let me remind you, age is just a number. Many a times, 80-year-old gentleman is probably as fit as a 60-year-old. And sometimes 80-year-old people may be bedridden. So what actually matters is not just the age, but the performance status of the individual. So you can go for noting the performance status of the patient. You can use the ECOG scale, or you can use the Karnofsky scale. And now you need to also think about what is the stage of the cancer. If it is a malignancy, you have to think about what is the stage of the cancer whenever you are looking or managing a symptom. So, and what is a future treatment plan for this patient? Is the patient on a curative cancer? Is the patient going? Is the patient on a palliative chemotherapy or a palliative cancer treatment, or is he just on supportive care? So if the patient is on a curative oncological treatment, this is a point where you have to be all aggressive. You might have to send the patient to the surgical oncologist. You might have to ask for, they're probably going to plan for resection and anastomosis and a colostomy. Or they are probably going to conservatively manage it and, change the chemotherapy. So that is when you think aggressive. Whereas as you go further in the disease trajectory, it's more to conservative treatment. And also you need to check if the patient is cachexic or having other concurrent illnesses, like, so, say, probably a cardiac illness or a chronic kidney disease. So even if the cancer is probably at a stage 2 or stage 3, if the patient is having a concurrent illness which is life-threatening, you will have to think twice. Coming to the disease factors, is the obstruction at a single level or a multiple level? If there are multiple level obstructions, resection and colostomy might be extremely challenging. Is it a proximal site or a distal bowel obstruction? Whether it is a functional obstruction or a mechanical obstruction? Is there ascites? Because most often ascites is considered with caution when considering for surgery. And if there is carcinomatosis peritoniae, where the entire peritoneum is seeded with metastasis. So these may be contraindications for surgery. So you also look at the technical aspects of how much to assess the invasiveness of the tumor through endoscopy or interventional radiology or any other laparoscopy procedures. And that is how you decide how the patient has to be managed. And mind you, it is a multidisciplinary team's decision that comes here. So, who carries poor prognosis? Definitely a patient who is aged and having cachexia with a widespread tumor with deranged metabolic parameters, one who is having ascites, a low serum albumin. Low serum albumin had also come in our previous presentation, isn't it? We all know that it increases the mobility of the patient, and probably the recovery of the patient is going to be much delayed or worse when compared to a person with a normal albumin. Severe nutritional deficiency, palpable abdominal mass, which shows that probably it is a really huge mass, previous radiotherapy to the abdomen or pelvis, which is going to tell you there are probably a lot of additions in there once you open it, a history of combination chemotherapy. Now, here what I mean is that, the patient has been tried several times with different regimes of chemotherapy and has failed to it and has yet progressed. That is what I was trying to mean here. And multiple sites of obstruction, poor peristalsis because of diffuse carcinoma peritoni, and poor performance status. Now, these are some points which are going to tell you that if these patients are taken up for surgery, they are going to have a very poor prognosis. So these are the patients who have to be channeled for conservative management. So how do you treat these patients? Laxatives. We did see in the previous slides on constipation of the different type of laxatives that we could use. And corticosteroids. How are we going to administer corticosteroids here? We did see in last class how we were planning to give for obstruction. To reduce the peritumoral edema, Dr. Rijju adds to that. Yes, we are going to give corticosteroids over here to reduce the peritumoral edema around the tumor, which is causing the mechanical obstruction. Either intrinsic or extrinsic or intramural, be it whatever, to reduce the peritumoral edema so that there is some space that occurs. When there is a tumor like that, you're reducing the peritumoral edema and there is some space over there in the lumen. And that is what we are aiming for with high dose corticosteroids. And how much would be the dose? How much would be the dose of corticosteroid and which corticosteroid?
Dexamethasone at the dose of 6 to 8 mg per 6 to 8 mg.
We generally do give dexamethasone in palliative care commonly. And in a case of malignant bowel obstruction, what we have seen clinically is that 8 mg does not suffice. We have to go for a higher dose of about 16 to 24 mg. And this is given IV. It is given once in 24 hours and preferably in the morning hours, not later than 5 p.m. because it, like I said before, it might interrupt the sleep pattern of the patient. And some textbooks might say 16 milligram, but in practice, sometimes we do give as high as 24 milligram as well. Well, I did have a patient who did get really excited and hysterical because of dexamethasone. So you might have to just watch out on some symptoms like that when high dose steroids are given to infants. And yes, antiemetics. So again, when you plan your antiemetics, you need to make sure how else it is going to help the patient. So your antiemetics, you do know from the last class, there are different types. You have prokinetic antiemetics, which are going to help in the forward propulsion So if you have a subacute intestinal obstruction, you would like to go for that antiemetic, which will help in the propulsion, forward propulsion. But if you're going to have a complete obstruction, what happens when you give something like a prokinetic? You are going to have the peristaltic waves coming there and mounting next to the site of obstruction, and then the other peristaltic wave coming behind and then mounting on that. And this in turn gives rise to a colicky pain. So try not to give prokinetic antiemetics for patients with complete obstruction. It can be given for those with incomplete obstruction where the patient is passing flatus. So you do know that by giving them a combination of laxatives where you're softening the stools and giving a prokinetic to propel to cause a forward movement of the intestines, it is going to help in evacuation of the bowels. Now, anticholinergic. Yeah.
Which laxative of choice would be what?
Laxatives, you can choose lactulose, you can choose stimulants. You can also choose stimulants, and stool softeners are also used.
Actually, the stimulants, won't they work exactly like you said, the prokinetic antiemetics? I mean, trying to propel something against an obstruction. So
yes, so you will have to use those in this one, in subacute intestinal obstruction. That is what usually is done. And generally, what we do is that we give oral laxatives and we also give suppositories, so that we make sure that there is no impacted, and we clear the peripheral area before we look into the intestines. And here, when I'm talking about anticholinergics, we have probably decided to give anticholinergics for the colicky pain. So we need to make sure that we are not combining it with prokinetics. Like we said in the earlier class, it might oppose, the action might oppose each other. So anticholinergics are also used as anti-secretory agents, like buscopan. So this might be given when probably that your patient is complaining of severe vomiting and you want to bring down the volume of the vomitus. Now, somatostatin analogs are also used for that. Analgesics can be given for controlling the pain. Now, surgically, resection of the bowel segment, colectomy, ileostomy, colostomy are all the different ways how malignant bowel obstructions are managed. And about NG tube insertion. This is always a topic of debate. When do you put in an NG tube? So a patient in palliative care comes to you with a malignant bowel obstruction. So do you put an NG tube or no? And some people, they even discuss about gastrostomy because the patient is not able to probably eat. Does it make any difference when there is a obstruction below that? And say suppose the obstruction in the colon is at a single point. Maybe you can put a stent. You can advise a stent. That can also be done. So NG tube insertions can be given to deflate the bowels, and that can be used as a temporary measure. But as much as possible, try to introduce sips of fluid, and if the patient is tolerating, liquid diets. So the patient need not necessarily be put nil by mouth. We can give sips of fluids if he is tolerating, or liquid feeds in restricted amount if he is tolerating. So metoclopramide, dopamine antagonists start with 10 milligram, 8 hourly, gradually increase the dose day by day. Higher doses, it can be given as subcutaneous infusions. And again, we can try other antiemetics like 5-HT3 antagonists and prokinetics only in partial obstruction. Now, haloperidol can be given for nausea and vomiting, 2.5 to 5 milligram over 24 hours as subcutaneous infusion, again for managing nausea and vomiting. Now, anticholinergics like hyoscine butabromide, 120 milligram per day subcutaneous can also be tried. Okay, and try not to combine it with prokinetics. Corticosteroids, dexamethasone, 16 milligram to 24 milligram. And like I said, it is given before evening hours. And how you give it for 3 to 4 days as a single dose. And then after that, you can taper it down and stop it. And if the vomiting subsides, you can continue the taper dose as oral steroid. Okay. And somatostatin analogs also, we had discussed octreotide, 300 micrograms. It's a very expensive drug. It's an expensive choice of management for your patient, but it will definitely reduce the secretion, slow down the motility, reduce splanchnic flow, increase the absorption of water electrolytes. So these actions have also to be kept in mind. And depot preparations are also available, which are again very expensive and usually not used actually much in palliative care. Now, medical management in a nutshell for your patient with the malignant obstruction is going to be a combination therapy of dexamethasone and metoclopramide, or if it is a subacute intestinal obstruction, if it is obstruction where you would like to manage the volume of the vomiting, you can also go for hyoscine butyl bromide and haloperidol also to control the nausea and vomiting. Now, this is a picture of the self-expandable stent. You can see how the stent is put through and the tumor obstructing mass there is a space that is created because of the stent. Now comes to important questions that patients ask you. What about the hydration? The patient is not having anything, the patient is excessively vomiting and not passing stools also. So how much should you hydrate the patient? So since the patient is not eating anything, do you suppose that, we should put the patient on IV fluids? What are your thoughts on it?
By monitoring the urine output, as per urine output.
So you feel that we could monitor the urine output, and according to that, we could balance the IV fluids, okay, to just keep a check on the hydration status.
Other clinical features of hydration like skin turbidity.
Okay, you would like to also assess how much the patient is dehydrated, check for signs of dehydration. Okay. So
and vitals.
Yeah, okay. You would also look at the vitals. Say, suppose the patient is going to hypotension. You would also like to correct that. Now, where do you draw the line? Like, is it something like, if you overhydrate the patient, are you calling in for trouble? Any thoughts on that?
Yes, ma'am. Yes.
Why do you say so?
That will increase the intestinal edema.
It increases the bowel secretions.
Bowel secretion.
Yeah, and that in turn is going to increase the vomiting.
Yeah.
Yeah, and excessive hydration can lead for patients who are bedridden. It can lead to increased secretions. It can lead to accumulation of fluid in the third space. So all that will lead to other set of complications. So you need to watch out on your parenteral fluid supplementation. So there was a question here. are there any recommendations for flatus tube insertion in distension patients to relieve breathlessness and abdominal pain? So basically, when patients are having an abdominal, an intestinal obstruction, there is abdominal distension, and which causes immense distress for the patient because the bowels are dilated, the stomach is dilated, the gastric, the stomach is also dilated. So in turn, to deflate a bit, the flatus tubes helps. The flatus tube helps. So to decrease the abdominal girth, it can be visibly seen. So I think symptomatically it does give relief to put a flatus tube in. So that is actually also practiced in our clinics. And oral feeds, how often do you give oral feeds? We had already talked about it. So there is no one-line rule saying. There is no one-line rule saying that your patients have to be nil by mouth. They can be given sips of fluid. They can be given liquid diet intermittently as they tolerate. So nasogastric tube or TPN. Okay, so again, would you like to advise your patient TPN during this time? Yes, I have suggestions here. Like in severe sarcopenia and cancer, cachexia, TPN does not help. Yes, so like I said in earlier class, TPN is that supplementation that is suggested for nutrition for someone who has a prognosis of more than 3 weeks. And it might not be actually effective for someone, or judicious rather, to use TPN for someone who is having a very poor prognosis and very terminal. And we have some comments here saying incomplete obstruction. We need to keep the PT patient nil oral and put on parenteral IV fluids. Okay. But what about the chance of bleeding from the tumor obstructing the rectum if we put in a flatus tube? We will definitely have to be cautious about things like that. And most often for patients with complete obstruction, we do a digital examination to check for impacted stools and things like that. So if we also know about the clinical diagnosis of the patient and the other clinical details, the imaging details, I think it will help us to be cautious enough before we intervene. And yes, Dr. Ramesh was also talking about if oral feeds are tolerated, that is the best. Yes. So these are just some answers that you would like to give your patient's family. So I have a quick case scenario here. Sarah is a widower. She's supported by her children living in the UK, and she's 62 years with stage 4 carcinoma stomach with metastasis to the peritoneum and anterior abdominal wall. And she has had palliative visceral gastrectomy and followed by chemotherapy. But what happened after 2 cycles of chemotherapy? They did a CT scan and they saw that the disease had progressed further. Now she is developing vomiting and abdominal colic for 2 days, but is still able to pass small amounts of stool daily. Now, what would you call that? Someone who has a vomiting abdominal colic for 2 days and is still passing small amounts of stool?
Partial obstruction.
Okay, partial obstruction. Sarah had vomiting 3 to 4 episodes, Sarah had vomiting 3 to 4 episodes per day, which was unrelated to meals. Vomitus was bilious with partially digested food. Now, what are we looking at?
Small intestinal obstruction.
Small intestinal obstruction. See, we have already come to the site without even a CT scan, right? So on examination, she was not dehydrated. Her abdomen was distended. Bowel sounds were sluggish. Palpable nodules on the abdominal wall, which was mildly tender. So we were looking at the partial obstruction, and we do know there is some amount of obstruction in the small bowel. So that's what we did. And And what was done? A nasogastric tube was inserted as a temporary measure for decompression, and a CT scan showed a small bowel obstruction. And as she is still opening her bowels, the impression was that a partial rather than a complete obstruction. And the intention of management was to reverse the obstruction. So she was given a suppository of bisacodyl and also metoclopramide and IV dexamethasone 8 milligram per day. So do you think that this prescription is good enough?
Yes.
Or would you like to make any change over here?
Ma'am, why dexamethasone?
Because this is a small bowel obstruction that is seen in the CT scan. She has got a tumor there because of the metastasis, and you would like to decrease the peritumoral edema, with which probably we are able to manage the subacute intestinal obstruction. So probably you would like to increase the dose of dexamethasone, because we know that for intestinal obstruction, 8 milligram probably might not suffice. And your suppository probably might not just be enough. You might have to also give oral laxatives. Now, this patient, for pain, she was put on fentanyl infusion. Okay. And there was no bowel action. The intravenous metoclopramide was further increased. And then she gets some improvement. Okay. And the nasogastric aspirate also reduced, the volume reduced. There was no vomiting. She is better now. So what does the clinician do? Takes off her nasogastric tube and she's put on oral pills. Okay. And intravenous metoclopramide and dexamethasone were continued for 2 days and stopped. Now, what is wrong here? Now, what is wrong here?
Dexa has not been tapered.
Yes, it has not been tapered. It has been stopped abruptly, isn't it? Even the antiemetic was stopped abruptly. So what happens? 3 days later, she starts vomiting again. And there's a large amount of bilious vomiters. And now again, she has started on metoclopramide and dexamethasone and ranitidine to reduce the gut secretions. And finally, her family was called down. The goals of care was discussed. And Sarah preferred that she kept the nasogastric tube continuously for decompression, so that she could also take her fluids orally along with that. They stopped the chemotherapy and she was continued on comfort care, and she was shifted for home hospice support. So I just brought in this discussion here so that we could see how to use what we have learned so far when a patient comes with a clinical scenario. So patients who are on colostomy, we need to advise such patients how to irrigate their bowel, because most often what happens is that the patients are cured, but because they have a colostomy, they shut themselves in their homes. They feel unclean. They do not get back to their work. So in order to regularize their bowels, they have to be advised bowel irrigation. These are the different components of the bowel irrigation procedure. And this is how, in this picture, like how it is shown, this is how a bowel irrigation is seen. It has to be practiced for 21 days at the same time in the morning. And after that, the patient gets into a habit of opening his bowels naturally at the same time. So now, by now, we know how to classify intestinal obstruction and understand and diagnose with the symptoms and even understand where the site of the obstruction is without a CT scan and how to manage them in palliative care. Thank you.
Ma'am, if you're giving DEXA for a short duration, like steroids given for short duration, they're generally not tapered. I mean, I'm not talking about a cancer case, but generally when we give it, say, if somebody with an acute bronchitis or so we just, if you're giving it for 5 days, they generally, the respiratory physicians, they say there's no need to taper. So I couldn't.
Here, basically the thing is that in patients with cancer, we are only treating the symptom. So the tumor is progressing by the day. So there is very high chances that the patient is going to develop the symptom again because the disease is progressing. So with the dexamethasone, what we have done is that we have only reduced the peritumoral edema. What about the tumor? There is no definitive treatment there to shrink the tumor. So we are anticipating the recurrence of the symptom there. So in order for the patient to have a prolonged kind of improvement, we slowly taper it down and we observe him.
Said that antacids cause constipation. So which antacids, the PPIs or ranitidine?
No, antacids, I would mean the aluminium hydroxide and the magnesium hydroxide combinations that come in antacids. So sometimes it can cause, like the aluminium hydroxide component can cause constipation.
Right. Okay. Thank you, ma'am.
Any more doubts?
Ma'am, is it safe to give a stimulant like bisacodyl all throughout the treatment duration of the opioids?
Yes, it is. It has a local action basically. It stimulates the intestinal wall and causes the propulsion action. So it is seen to be quite safe. We have not encountered any such untoward events among our patients, except for some. They say that they get a colicky pain when they use the stimulant, but other than that, it's very safe.
Thank you.
So if morphine continues lifelong, so does the
laxative.
And ma'am,
most often we have to combine it with a laxative.
If someone goes for a home visit and does a manual evacuation of feces, does that, there's a possibility of causing abrasions or bleeding? How is that managed at a home level? Or does that, is the bleeding self-limiting?
Most often, if it is just an aberration which is caused by the impacted fecal mass, and as you are doing a digital evacuation, it is probably just a small aberration that is caused there. But if you are having a torrential bleed, say suppose you're having a rectal tumor over there, and you have happened to unknowingly abrase the tumor and it is bleeding from the tumor, then probably you will have to go for hemostatic agents, like tranexamic acid, and the patient will have to be referred for probably radiotherapy and things like that.
It could be on aspirin. I mean, since they are elderly, and then probably after you have completed your visit, you get another call saying that okay, now he's developed this. So then they just ask them to get hospitalized.
An immediate measure, what you can do is that you can ask them to take an ethamylate or a tranexamic acid, which will help to control the bleeding. And if he is due for his aspirin dose or something, that can be advised. And that is usually how it is done.
He can proceed and take the aspirin dose.
No, he cannot.
Madam, usually when we go for home care, or when you do any procedure, even very small procedures, we very meticulously inform the patient as well as the bystanders about the pros and cons and get an informed consent. That's very important because anything can happen at here, and they'll blame you later on. And then we tell them they can call us anytime if there is any untoward effect, or if it's an acute bleeding, like as you said, if there's a tumor which we have manipulated and started bleeding arterially, they can immediately come to the hospital. So we tell them uphand before anything happens.
Yeah.
So that's very important when we do home care.
Yeah.
So, Dr. Biju, you would take a consent for a manual evacuation also?
Yes, I will. I take consent for every procedure we do. Even giving an IV antibiotic, I take consent, because you can have an anaphylaxis on bed, or probably a delayed anaphylaxis. It had happened to me. I had given the antibiotics. I was there with the patient almost for 1 hour. She had no problem. I went home, and then I get a call frantically saying that she has got edema. She is having stridor. Then I went back, and then I told her, but I had told them prior hand that this could happen. And so they were not very upset about it, but we could save the patient. We saved the patient, but it can happen. So we get that signed by the relatives.
Thank you.
Medical legal issues are very important in palliative care, especially in home care, and nowadays, especially very, very care.
Thank you. So just want to give you some hint about the use of bisacodyl, that is stimulant laxative in the standard section. So one thing is that if the pain is colicky pain is mild, then you might be able to use metoclopramide as well as bisacodyl along with a lubricant laxative, that is with a liquid paraffin. That will decrease the colic. But if the patient has severe colicky pain, then maybe for a day it is better to withhold metoclopramide as well as bisacodyl. Give dexamethasone, which will reduce the peritumor edema, and that will open up a small passage. By the next day, the pain will be less. So you can administer the stimulant laxative and metoclopramide. Okay. I think we have to move on to the patient story now. So which will be presented by Dr. Ravi Kiran. Dr. Ravi Kiran.
Dr. Ravi, you are muted.
Good evening, everybody. I'm a radiation oncologist working as a palliative care physician. Next slide, please. The patient, female, 42 years old. She is a ovary patient post-op and post-chemotherapy, which was received outside somewhere, and she has presented to us at the time of admission with subacute intestinal obstruction. Next slide. The presenting complaints were vomiting immediately after oral intake since 4 days, not passing stools, stomachache, loss of appetite, and generalized weakness. Next slide. The patient complains of history of present illness. The patient complains of whole abdomen pain associated with vomiting immediately after oral intake and was constipated since 4 days. She has anorexia and early satiety with small meals. That was since 2 months. She was passing urine 2 to 3 times per day. Sleeplessness since 4 days, and patient needs support for daily activities. There was no fever, chronic ailments, or any communicable diseases. Next slide, please. Next slide, please. On examination, general condition was suboptimally fair. Patient accompanied by husband and elder daughter. She was conscious and oriented to person, place, and time. Patient is upset. History is given by patient herself. No icterus, mild pallor. She was not cachexic. No edema, no lymph nodes, no cyanosis. Patient prefers to lie down on couch to sit, probably because of the weakness. The vitals at the time of admission, at the time of visit, BP 100/60, respiratory rate 19, heart rate 81, temperature 98. The pain score at that time, abdomen pain was 5/10, and distress score 6/10. For abdomen, tenderness all over abdomen, minimum fluid, but there is no fluid thrill elicited. They were hypoactive, bowel sounds were present, but they were hypoactive. Rest of the symptom examinations were unremarkable. Next slide, please. Next slide. We have done the routine CBC. The CBC, the more or less the normal. The serum electrolytes, the potassium was imbalanced 2.97. The CA125 which we have done is 9014. X-ray erect abdomen was done. Multiple fluid levels in the abdomen. No free gas is seen. USG was done from the outside hospital, in which they have given bowel loops are dilated and so sluggish peristalsis, query SIO, and X-ray correlation is needed. The patient was reported to some local clinic where they have not admitted the patient and they referred back to home. So they have come here to us. Then we assured the family and patient that we will admit and consider for symptomatic relief. We explained the family and patient what is happening with her, that is an obstruction and leading to discomfort. We explained them to keep the patient nil per hour and NG decompression will be done. So NG tube for aspiration, steroids, PPIs, IV fluids, electrolytes correction, and we catheterize to monitor input, output, and vitals atarly. Next slide. The psychological aspect, patient is young and has lots of hopes and wishes to fulfill her dreams regarding her children's studies, marriage, settlement. She is prophylaxically treated and with chemotherapy, and despite recurrence occurred, she worries about welfare of children if anything happens to her. The daughters are 18 and 12 years. She wants to be fit for chemotherapy. Her husband is the breadwinner and no further support. Monthly income is 15,000 and on rent. She understood the prognosis, but she's not able to accept and acknowledge. She's in the bargaining phase of the grief cycle at the time of admission. Next slide, please. The medications, we have kept the patient nil per hour, but we asked the patient to have salt and soda gargles initially, and an NG tube for aspiration. We have given injection dexamethasone 12 mg IV stat, and then we tapered in due course of time. Injection ranitidine 50 mg BD. We have given hyoscine butyl bromide 10 mg over 6 hours, and TID to escalate if required. And to correct the potassium, we have given KCl 2 ampule in 1 unit NS over 6 hours to normalized PC enema. We have treated the patient for 10 days. She was settled her distress and then later discharged. Goals of care were discussed with the caregivers and the patient. Next slide, please. The main concern, the pain abdomen, the vomiting after oral intake. She is not passing stools as previously, not able to eat, can't able to spend the quality time with the children. And she's unable to accept the prognosis that she is not further fit for chemotherapy. As we have discussed in our board meeting that is she eligible for further chemotherapy cycles, then we decided it is like end of life care. It's the best supportive care at this moment will be the best to her rather than giving her with chemotherapy, which she was taking somewhere elsewhere outside. She can't able to, so this became a major concern that she will not be able to eligible for chemo and she can't rid of the cancer. So what would happen to her children if something happened to her? Next slide, please. So she's a summary. She's a 42 years old female with a recurrent CO ovary post-op, post-CT. She has been multiple lines of chemotherapy outside, and she has presented to our institute with subacute intestinal obstruction. She was planned for best supportive care by all the oncologists, expert panel, the tumor board meeting to the best interest of the patient. Next slide, please. It became very difficult to us to explain the disease prognosis by the new doctors because she's the first time which we encountered and she encountered us with a subacute intestinal obstruction, discussing the goals of care. Even though we discussed the goals of care after settling her symptomatology, but still it became very difficult to build a rapport in a few sittings, and avoidance of futile care, lack of hospice in our facility, and because we located in a very remote rural background setup, even to connect to the city also, we 25 to 30 kilometers they have to go there. And breaking bad news, it's become very difficult for us because it is the first time we have seen the patient and decided that no more further chemo. So it became very hard on them, which we tried to manage with the help of counselors, with the help of the senior doctors, with the palliative care physician, but it still became hard to us. Next slide, please. Thank you.
Thank you, Dr. Rebecca. Anybody want to comment on this patient story?
Can I know
And
why
the patient,
the salt and soda gargles? Can I know the rationale for? Is that for
because
oral
we keep
hygiene?
the patient on, we keep the patient on NPO. The gargling, which because of the dryness, the oral candidiasis can predispose. So we started the gargling thing. At least she will have the oral care and as well as the moist of the oral perioral area. And when she started settling down the symptomology after 5-6 days, we started clamping the NG tube and started oral feeds, minimally started. And when she's accepting the oral feeds, we withdrawn the NG tube and we started the oral medications of DEXA and the rest of the things. And when after 10th day, for the past 9th and 10th day, we kept her on observation with the diet as well as the oral medications. Is comfortable and passed stools, and then we discharged.
Thank you.
Somebody else was talking.
Actually, as the doctor said, it is very difficult to break the bad news to the people who are coming to you the first time, especially after treating from somewhere else, because they are not known to you and you don't know them. So the trust factor is very difficult to develop on the first time. So it's probably it might take 2 or 3 sessions until they come to know us and accept what we are talking about. It's very difficult situation. I think that shows the importance of incorporating palliative care from somewhere early in the treatment of the patient, because if these things are unexpectedly appearing, like the patient, in spite of all the chemo and all the treatment, she has gone into stage 4. So at that time, it's very difficult to go and tell them that the treatments are no more effective and it's futile, especially the new doctors. So it will be better to incorporate palliative care from the early stages of the treatment.
And Dr. Ravi, what was the insight of the patient?
So she knew the prognosis. This is a stage 4, but she wants that after settling the obstruction, she wants chemotherapy again. She doesn't. She's in the bargaining phase that yes, I should settle the obstruction as fast as it could, and then again I take the chemotherapy. I will fit for chemotherapy. She is in the mindset of that. We just like to break down that notion with the counselor, that what is actually happening and what would it will lead to if further chemotherapy is given. And we also discussed with the written a letter where they have taken the chemotherapy that it's obstruction and we have decided this is the thing. So to plan accordingly the thing next when they come follow up with them. And the caregiver, the husband, has accepted and understood, but the mother, she wants that if she get rid of the cancer, she will be taking care of her children. She is only in that notion. I have to take care of my children at any cost.
Okay. So there were other family members, a husband or?
So only the 2 daughters, 18 years and 12 years. The 12 years, sometimes 18 years girl and sometimes 12 years girl used to come, and the husband. Only the 4 of them, they live in a rented home. There is no any other support.
So the children and the husband knows about the
we have
disease.
Yes, sir. We have discussed them and they have accepted this thing, but the patient herself is like yes, I have to get it treated, I have to get it cured.
Okay. So probably, I don't know whether she's in denial. And what happened to her? Do you
So
know?
it was she's not present now. We called her after 3 weeks. What is the status? She was last month December. She has expired, demised in the chemotherapy where they went. They went there, but in a critical condition over there, and she left
Okay.
in the month of December.
Okay, Vineetha, yeah, Dr. Gadasaraj.
Sir,
Yes.
sir, we have a very similar case with us right now. She's been with malignant bowel obstruction for the last 3 months, and the thing is, she's on TPN and other. Um, she is putting TPN, like she wants TPN and she's on TPN. So for the last 40 days, she's been on TPN. So she is like, so it was something like they're keeping her alive artificially completely. So whatever they're giving something oral, she has a Riles tube and she has an ostomy as well. The ostomy is not functioning, and she's underwent a re-surgery for another ostomy. They did 2 ostomies now, and she wants hope to live. She's similarly around 42, and she's a little younger. She's around 38 years of age, and she has a daughter. She around 10 years of age. So she wants to see the daughter live, and she's not able to accept the whole scenario. And she underwent 2 surgeries. She wants to undergo one more surgery to get the ostomy done for her, and she wants to eat something and live. So she's on 40 days of TPN, and she doesn't want to stop the TPN.
Have you, sir, general health condition?
She's not able to get out of bed for the last 1 week, and she gets admitted on and off for some electrolyte correction and all, like 2 weeks once she gets admitted, and then she goes back home, and at home she is putting TPN. She has a nurse who comes connect the TPN every 20 hours. They change the bag.
Okay.
There's nothing else going on.
I think there
And
are
we give
lot
irrigation
to
to the
discuss.
ostomy, which is like emptying on and off some collection. But whatever she has a rice tube also, she drinks something and everything comes to the rice tube. So it is like an non-acceptance that's still going on, and the husband is still supporting him.
Okay. So I know there are a lot of things to discuss in the patient survey that you have already got, but we will not have time to discuss that. I would ask Vineetha to have her comment on this patient.
Yeah. So well presented. It's a nice case to discuss. Here, it just blankly points out the fact that, how goals of care have to be discussed by the primary treating team. This team comprises of the oncology, the palliative, the psychology, the team, all of them. It's a multidisciplinary team. So definitely the goals of care, the prognosis of the disease. Let's start from the diagnosis. The diagnosis, the treatment, what is being planned, and if the treatment does not go as planned, what is expected and what are the goals of care that the patient should pre-plan. All this should be discussed primarily itself, because that is when this becomes difficult on how to deal with them when things are going not as expected. And again, then when the new set of people come in, always it takes a long time for them to accept, especially when you are going to break the bad news, because be it how much of a bad clinical condition the patient is in, always the patient and the family wants to hear something good. When you tell them that, yeah, it's okay, it will be fine. No, that's what they want to hear. But having to tell them to make them accept the truth, it requires training in communication skills, and how to break bad news. There is a very meticulous way of how it has to be done. And that is a very essential part of palliative care. Again, one more thing that I wanted a clarification, Dr. Ravi. You had mentioned about giving injection Buscopan in a 100 ml NS over 6 hours. Actually, I am quite new to that way of administration of Buscopan. Dr. Ravi?
Don't have the syringe pumps, so we need to maintain the IV fluid. So the only method we can have is the adding the 10 mg iosine into the NS. If we don't have the syringe pumps. So initially we thought of escalating to 40 mg, but her BP is already 100/60. So even the BP just fluctuates if we increase the iosine also at times. So we need to monitor the BP and also escalate the iosine butyl bromide. There will be a sudden drop if we don't monitor appropriately. So, but the patient with 30 mg, the colicky pain has come down from 5 to 3, and she's able to accept the oral fluids in the due course of time. So we couldn't, we thought, let's see if we need to titration above or later. That's the only thing we added in that way, because we have no other option of, we don't have syringe drive pumps for the continuous infusion of butyl bromide.
Okay. You didn't want to give like steady doses of 10 milligram, like have a subcut in situ, and at that particular, like even if it is like 6 hourly, give a push of Buscopan.
Ma'am, we have started in this way.
No, I was just thinking that 100 ml is how it would actually add into the 500 ml is how it would actually add into increasing the secretions for vomiting further to worsen and things like that. I was just thinking around that.
We thought this is the best to the patient. And the subcutaneous infusion also, our nursing staff is not much confident enough. So we have to rely on the IV line. That's the problem.
Yeah, I think so. Yeah.
Madam, one thing you said about a multi dimensional team of oncologists and palliative physicians and all trying to take care of the patient from the beginning. Unfortunately, I worked in a corporate sector hospital. It doesn't hold any water there, because the oncologists won't even allow us anywhere near their patients until it's so late that the patient is gasping. It's a very tragic situation when we are given over to the patient. There's nothing much more to be done. So I used to keep on requesting them try to incorporate us into the team, so that the patients and the families will get to know us also and get to accept us as a part of the team, because we are strangers, and so it's so difficult to make them accept. Even take morphine. When we say, please take morphine, they said, no, the other doctor did not say that we have to take morphine. So they go to the other doctor and say, should we take this? And then he has to make a call whether yes or no. So but we used to tell them, but the reality is that it's so difficult in the corporate world.
Yes, I agree. Sometimes it is very challenging.
Yeah.
Anup, can you show the medications slide? Yeah.
Is it visible? Sunil sir, is it visible?
Yeah.
Slide is visible.
So maybe ranitidine can be increased to 8 hourly. if there is a lot of vomiting. Then how severe was the colicky pain?
Sir, the colicky pain was 5/10, but after of 2 to 3 days of this medication, the colicky pain was reduced. She felt better, but she hasn't passed stools even after 3 days. But after 6 and 7 days, she passed stools, hardened stool.
Okay, I just want all of you to know that even opioids have some antispasmodic effects. Okay, so it will also help in colic. Opioids, even though opioids will also produce constipation, but if the patient has continuous pain, then we have to give opioids. It is not contraindicated. So if this patient had continuous pain, you might have used opioids, and that will take care of mild colicky pain also. And dexamethasone will also reduce the peritumor edema, which will also reduce the pain, as generalized pain as well as colicky pain. Then I think maybe even we can think of adding metoclopramide, discodyl, as well as liquid paraffin if the patient had only mild pain. And of course, high rectal examination, and if needed, high epenema.
Sir, if we have the syringe pump drives, how would we give these medications like for continuous infusion? If we have the syringe pump drives, then.
Okay, so if you need to give metoclopramide, actually metoclopramide need to be given by continuous infusion, because if you give metoclopramide 8 hourly or 6 hourly, 4 hourly, etc., then it can produce colicky pain, because at some point of time the concentration of metoclopramide in the blood will be higher. So that can produce some colicky pain. So to have a sustained blood level, it would be better to give metoclopramide by continuous infusion, either IV or subcutaneous by syringe driver. Or if you do not have syringe driver, maybe syringe pump. So I don't know how many of you have syringe driver, or how many of you have seen syringe driver. It's a small device. It is not like a syringe pump. The patient can actually hang it with a bag, and patient can be mobile. But with syringe pump, the patient need to be in the bed.
The injection, the buscopan, how well we can improvise in this case if needed?
Okay, usual doses of hyacinth-butyl bromide required would be in the range of 80 to 120 milligram. That's the usual range, but there are literature in which the patients, in which the doctors have used up to 300 milligram per day. So you have to also see the side effects of anticholinergic side effects when you give increasing in doses of hyacinth-butyl bromide. Okay, so I think we have to stop now. So thank you, Dr. Vineetha, for covering the JA symptoms in these 2 sessions, and that was both of them are very excellent sessions. And thank you, Dr. Vikiran, for presenting this patient story, which actually was a revision of the class by Dr. Vineetha about intestinal obstruction. And thank you all for your active participation. So we will wind up for today, and we'll see you on Friday with another class. So thank you, everybody.
Thank you, Dr. Sunil, and thank you, Palliative India, for having me here. And a big thanks to all the participants. You really make the class enjoyable with your responses. Thank you so much.